have the lead stay on the patient, have the MA bring you the report so you can review the report, make sure the lead placement is correct. And then if you're happy with the report, then you can have the MA take the leads off that patient. So that's just a quick reminder of getting to know your EKG lead placement. Let's quickly review our electrical conduction system. So by now, you know that everything starts in the right atrium with that SA node that paces and stimulates the AV node, and that then travels down the bundle of His and into the left and right bundle branches to help with that ventricular contraction. So that is the loop. So what does that look like on your EKG? So the P wave is your atrial contraction, what we call atrial depolarization, and your QRS wave is your ventricular contraction, what we call ventricular depolarization, and your T wave is that ventricular repolarization, so allowing those ventricles to fill back up. Parts of the EKG, so you're all pretty familiar with your P wave, your QRS complex, your T wave. Your EKG is going to be printed on graph paper. So I want you to get comfortable with that because that's going to really help you when you're interpreting the EKG. Each one of those little boxes is about 0.04 seconds. So if you count them out, you're looking at these darker lines. There are about 5 little boxes between these darker lines. So 4 times 5 is 0.2 seconds. So this is all happening pretty fast. Where this is going to come in is when you're looking at your rhythms and you want to calculate your PR interval. So that's the start of the P right up to the Q. You're going to calculate your PR interval, and normal PR interval is 0.12 to 0.20. So that's between 3 to 5 boxes. So you're going to be counting those out. Then you're going to look at your QRS complex. You want to make sure it's less than 0.12, so less than 3 boxes. And then you're going to look at your T wave as well. You have your ST segment, which is between the S and the beginning of the T wave. And then you have your QT interval, which is the Q to the end of the T. So all of that is going to be really helpful as you're interpreting your EKG. Also, we talked about lead placement. So as the conduction is moving towards the leads, you're going to see that upward deflection, which is a positive deflection. And if it's moving away from a lead, then you're going to see that negative deflection or downward deflection. So all that, we'll talk a little bit more about that in just a sec. This slide is basically just to remind you about normal heart rate. I know by now you're very familiar with the normal heart rate. Adult normal heart rate ranges between 60 to 100, and that's what we're going to be focusing on today when we're talking about our arrhythmias. If you're a family nurse practitioner, you probably already know that the heart rate normal starts off a little bit high and kind of gets closer to that adult rate by 6 years old. So if you're doing 12 leads, it's going to look a little bit different with the normal heart rate if you're doing 12 leads on kids. But we're going to talk about adults today. So when you're looking at a 12 lead, it can feel really overwhelming at first. So where are you supposed to look? What are you supposed to do first? I recommend you come up with a systematic approach to looking at it. This is just the way I like to do it. You can come up with your own approach. But generally what I like to do is get general impressions, take a look at it. Is there anything that's jumping out at me? Then I like to make sure that all the parts are there. Is there a P for every QRS? What does my T wave look like? And then I calculate my PR interval, my QRS interval, and then you're going to calculate your rate and then identify your rhythm. You're also going to look at the QRS axis. So we'll talk a little bit about that. That can also be a little confusing at first, but once you practice it, it'll make more sense. And then we're going to talk about hypertrophy and then identifying ischemia or infarct so that you can intervene quickly. So you always want to make sure that you have at least a 6-second strip. And it's not really labeled here on the slide, but on a 12 lead, you're going to see some darker lines every 3 seconds. So you just want to make sure you at least have 2 3-second dark lines. So that's a 6-second strip. So as I'm looking at this strip, like I said, the first thing I want to look at is there anything jumping out at me? Do I have a P for every QRS? What does the T wave look like? And then I want to start calculating my PR interval and my QRS interval. So is that falling within the normal interval, or is it prolonged? Am I seeing a wide QRS or a narrow QRS? And then I want to calculate my rate. There are different ways to calculate rate. My little shorthand that I like is counting the R to R cycle. And so don't get confused by this. So people will think, oh, if I just count the R, 1, 2, 3, that's going to be my rate. So R to R cycle talks about going from one R to the other. So this is 1, going from one R to the other. So that's one cycle. So you're going to count your R to R cycles in a 6-second strip and multiply that by 10 to get your rate. So in this case, we have 1, 2, 3, 4, 5, 6, 7, 8 R to R cycles. I multiply that by 10, and so the rate is 80, which is normal. So that's a quick little shorthand. So this strip is a normal sinus rhythm. We identify that there's a P for every QR complex. The PR interval is between 3 to 5 of those small squares, so it's between 0.12 to 0.2. That QRS complex is narrow. It's less than 0.12, so it's less than 3 small blocks. And the rate is 80, so it's between 60 to 100, and it's a nice regular rate and rhythm. And then the QT interval is also normal. So again, QT interval is going to look at the Q to the end of the T. The reason why I bring this up is because the boards really likes to ask about prolonged QT and what is the danger of prolonged QT. And so just remember, prolonged QT can lead to dangerous ventricular tachycardia, such as torsades de pointes. So keep that in mind as you're studying. There are different things that can cause QT prolongation. You want to watch those patients closely. So the QRS access. So basically, this feels very daunting at first, and there's a lot going on in different leads, but what you need to know is it's just telling you the direction that the conduction, the electrical stimulation is moving in the heart. And normal access is moving slightly to the left. So when you see, you're looking at the lead 1 here and AVF, right? So those are the ones you're going to be looking at when you're wanting to look at QRS access. And remember what I said, if you're moving towards a positive point of the lead, you're going to see an upward deflection. And if you're moving away from it, you're going to see a downward deflection. So in the first lead, the positive is right here on the left side, the negative is on the right side, and then in AVF, positive down here, negative is down there, or up there. So normal axis is going to be between negative 30 degrees and positive 90 degrees. The heart, the axis is always pointing slightly to the left. When you're looking at a lead in lead 1, if it's positive, it's gonna be on this side. And then say it's positive in AVF as well, it falls somewhere in that normal axis. Now, if you're looking at lead 1 and it's positive, so again on this side, but AVF is negative, that means there's more likely going to be a left axis deviation, right? And then similarly, if you're seeing negative in that lead 1 and you're seeing positive in AVF, then there's probably a right axis deviation. And then in really extreme cases, if you're seeing negative on both, so negative lead 1, negative AVF, that's an extreme axis deviation. And in that scenario, I want you to first check the leads and make sure that they're not flipped around. And to be honest, I've never seen that extreme of an axis deviation. I think that patient's going to be in a lot of trouble if that's what you're seeing and it's not a lead issue. But don't panic. Don't let the machine overread it for you. Just check those limb leads. And then the other thing I want to point out is in hypertrophy, so enlargement of that heart muscle, you're going to see the axis displaced towards the hypertrophied side, right? Because the muscle is going to be thicker, so it's going to take longer to work through, the conduction is going to take a little bit longer to work through those heart muscles. And an infarct and an infarction, those cardiac muscles are dead, right? So there's actually no electrical conduction moving through. So you're going to see the axis pointing away from that area of infarct. The left ventricle is the area that will most likely be infarcted. So if you see a right axis deviation, I want you to think infarct, okay? So with hypertrophy, I debated on how in depth to go through this with you, but what I really want you, the key takeaway, I think, is to know that hypertrophy can also be evident on an EKG. And so you have two different types. You have atrial enlargement, and then on the EKG, you'll be able to identify the left and right side once you get really good at reading EKGs. And then you have ventricular hypertrophy, and left ventricular hypertrophy, or LVH, is the most common. And you're going to see these in the chest leads, and there's a little calculation that you can use to calculate that left ventricular hypertrophy. If the machine will probably read it for you, but you probably want to get good at recognizing it on a 12 lead in that V1 and V5. But basically, if the S wave in V1 plus the R wave in V5 are more than 35 millimeters, then there's LVH present. So you can play around with this, but mostly the key takeaway from this slide is that you are going to see hypertrophy on that 12 lead EKG. So if you see like a biphasic wave with that, diphasic wave with that P wave, what does that mean? That's probably atrial hypertrophy. And then if you're seeing really spikes with that S wave and the R wave, you're probably looking at left ventricular or just ventricular hypertrophy. All right, so this is a very important slide, so I want you to pay attention to this part. We do not want to miss ischemia, injury, or infarct, right? So as you know, the heart supplies its own blood. So the heart derives its own blood supply from the coronary arteries. The 3I triad, so ischemia, injury, infarct, they're the basis for recognizing and diagnosing myocardial infarct. So what does that mean? So ischemia is just reduced blood flow or poor blood supply to an area, and you're going to see that most likely in an inverted T wave. With an ST elevation, that's going to be acute or a recent infarct. So an ST elevation means something's happening in that moment acutely. With an ST depression, that can also indicate a different type of infarct. It could be digitalis. So you want to look for both ST elevation and depression, but basically infarction means there's no electrical impulse. Those are dead cells and they cannot depolarize normally. So the Q wave is also going to help you identify if there's infarction. And there's insignificant versus significant Q waves. Basically, significant Q waves usually are wide and deep. So you're going to see a Q wave that is at least one of those small squares, 0.04 seconds, and it's going to be deeper. It's going to be 1/3 of the size of the QRS complex, and you're going to see these in lead V1 and V3. So these are the things to look out for and make sure that that patient is getting the care that they need in a timely manner. This is emergent, right? You don't want to miss ischemia or injury to the heart. All right, so let's get into the arrhythmias. Hopefully you're still with me and that all made sense. And we're going to practice now trying to identify different rhythms. So first things first, remember that systematic approach when you're looking at a lead. First, just scan it, get your general impressions. Is anything popping out at you? Then check for the parts. So here we're going to check, does it have a P for QRS? P for QRS, P for QRS, P for QRS, P for QRS, yes. I don't see any inversion in the T waves. Now let's look at the PR interval. So is it between 3 to 5 of those small squares? Here the interval is between 0.12 to 0.2. That QRS complex is narrow, that's less than 0.12. And then let's calculate the rate. So this is a 6-second strip. This is going to be 3 seconds, another 3 seconds. So let's make sure we have a 6-second strip and calculate those R to R cycles. So here's 1, 2, 3, 4. There's a little bit here, so I'm going to say this rate is about 45. And so that is definitely lower than the normal heart rate. So remember, normal heart rate in an adult is between 60 to 100. So this is a regular rate, but it's less than the normal rate. So this is sinus bradycardia. Now, sinus bradycardia can be normal or it could be abnormal. So your history is going to come into play here. Is this patient symptomatic? That's going to be really important. Is this their baseline? Is their heart rate always a little bit lower because they're on a beta blocker? Are they very athletic? Do they go running every day? Are they a marathon runner? You might see sinus bradycardia as their normal baseline in those patients. But if they're symptomatic, so if they are describing symptoms of presyncope or syncope and shortness of breath, and they're having symptomatic sinus bradycardia, that is concerning, and you want to figure out the cause and treat the cause and monitor this patient closely. This would require acute monitoring and emergent care. So it may not always need fixing, but it is an abnormal rhythm. So I want you to pay attention to sinus bradycardia. So sinus tachycardia. So we're going to do the same thing again. General impressions. Is there a P for every QRS? There's the T wave. How's the PR interval looking? So in sinus tachycardia, the PR interval is normal. The QRS is narrow. So remember, in these atrial arrhythmias, they're going to be narrow QRSs because that's before the AV node. And so then you're going to start calculating the rate, and you'll see in sinus tachycardia, the rate is usually above 100. A lot of people get sinus tachycardia confused with SVT, which is supraventricular tachycardia, which I'll talk about in a little bit. And we'll talk about the difference between sinus tachycardia and SVT, supraventricular tachycardia. But basically, what I want you to remember is sinus tachycardia is generally between 100 to 150 beats. So it's typically over the normal 60 to 100, but it's less than 150. There's also usually an identifiable cause. So if that patient's coming in with a fever, upper respiratory infection, you're probably going to see an elevated heart rate. And if you've got an EKG on that patient, you'll see sinus tachycardia. Also stress, anxiety, caffeine, exercise, that can also make the heart rate go up. I had a patient the other day who was being overtreated with thyroid medication. So she was feeling fine, but she noticed on her Apple Watch that her heart rate at baseline was at 120, and that was unusual for her. She was a runner. She'd go running every morning. She could do her normal activity, but her resting heart rate all of a sudden started to be 120. So we investigated a little further, trying to find out what the cause was, and it turned out that she was being managed by a wellness provider who had her on 2 different T3s. And so between that and losing a lot of weight since her last visit in November, and when I was seeing her a couple of weeks ago, she was being overtreated with her thyroid medication. So she had developed sinus tachycardia. So once we reduced her medication dose, she went back to normal sinus rhythm, but you definitely want to find out the underlying cause and try to correct sinus tachycardia. Typically, I'll see this in my diabetic patients too with uncontrolled diabetes. If their blood sugars are really high, they're always a little sinus tachycardic. And so the underlying cause that we need to fix there is getting better control of their blood sugars, because their blood sugars are so high that blood is really viscous. And so that heart is pumping a lot faster, right? So trying to identify the cause and correct it. But again, it may not need fixing if it's just an acute viral infection, and you just have to make sure that patient stays really well hydrated. So figuring out the underlying cause and getting them to cardiology if you're worried that it's something that does need to be fixed or at least investigated. All right, supraventricular arrhythmia. So this is SVT. I want you to look at the supra. A lot of people get this confused with ventricular tachycardia, or they get it confused with sinus tachycardia, and they don't really understand the difference. So supraventricular tachycardia, supra means above the ventricles. And the other clue that it's not a ventricular tachycardia is that QRS complex is narrow. So you're looking at the QRS complex, is it wide or narrow? And it's less than 0.12. In this rhythm, there's no P wave. So you're looking at the parts of the EKG, and I don't see a P wave for the QRS. I see a T wave, but I don't see a P wave. And that's because this rhythm is so fast that the P is hidden within the T. So you're just seeing kind of a blend of that P and T wave. And the rate is going to be more than 150. And so this patient is definitely the rate is a lot faster than just sinus tachycardia. The other difference between sinus tachycardia and SVT, so sinus tachycardia typically it's not sudden and there's really a reason. So we talked about a couple of reasons for sinus tachycardia, right? So fever in a patient who's not feeling well, they have acute respiratory infection. In that patient that was being overtreated with thyroid medication, or in your diabetic patient, there's usually an underlying cause. With SVT, it begins and ends suddenly. So it's a premature beat that gets caught in a loop until something breaks the cycle. And that's why one of the interventions that you could try, you'll see here, is that Valsalva maneuver. So having that patient take a deep breath and bear down like they're having a bowel movement, sometimes will snap them out of that loop and back into a normal sinus rhythm. So figuring out, again, the cause of the abnormal rhythm and trying to fix it. And then in this case, you most likely probably want to, if you can't break them out of that rhythm, you want to pace that patient on a beta blocker, a calcium channel blocker, and get them over to cardiology, because you don't want it to then develop into a secondary conduction issue that could be more life-threatening. So definitely an abnormal rhythm. All right, so atrial fibrillation. I would imagine most of you recognize atrial fibrillation. It's very easily recognizable. It's a classic. This is the rhythm that you're going to see most likely in the clinic in your patients. There are two different types of atrial fibrillation. So basically, what atrial fibrillation means that you have multiple ectopic atrial spikes. So there's no real P wave. You see that fibrillation on that EKG. You see fibrillation between the QRS as you're seeing multiple ectopic foci in that atria. You have paroxysmal versus persistent atrial fibrillation. So some patients can persistently be in AFib, meaning all the time. Some patients can go in and out of AFib. We call that paroxysmal. And then you can have symptomatic versus asymptomatic patients. So some patients may really feel when they're in AFib and it really bothers them. Some patients, they feel they go in and out, it's not bothersome. Some patients don't even know they're in AFib. You listen to their heart, you feel their pulse, and you're like, oh my God, you're in AFib. And they're like, I am. And it doesn't bother them at all. But the key takeaway with AFib, what I want to point out, is that patients with AFib need to be anticoagulated. So that's really important. And the reason for that is because of the disruption in that if you're getting multiple stimulus from the atria, that blood flow is not really coming out of the atria. You're getting a little stasis in that blood in the atrium. So that can develop into a clot, and they can throw an emboli or have a stroke. So it's really important to put them on anticoagulation to make sure you're avoiding or reducing the risk of stroke. The other thing for patients with AFib is they should, if they're not already seeing cardiology, you should refer them to cardiology just so they can be further evaluated and to see what their intervention options are. Nowadays, more and more cardiologists are recommending ablation for atrial fibrillation, and it's important for you to understand what that is. What's the difference between cardioversion and ablation? And because your patients are going to talk to the cardiologist, but then they're going to come to their primary care and ask for your opinion. So you should be familiar with those different interventions, and also make sure they understand the risk versus the benefit. So often ablation could be successful or not successful. It could be successful temporarily, and then that patient could go right back in AFib. So they really should be directed to talk to their cardiologist about the risk versus benefit of the procedure. And then, of course, all patients with AFib should be assessed for stroke risk using that CHA2DS2-VAS score system, and they should be anticoagulated. And also, they should be rate controlled with a beta blocker. So when you're seeing your 12-lead EKG, if it's someone that you're seeing for your annual visit and they do see cardiology and they're always in AFib, or they have paroxysmal AFib, you can write right on your report, rate controlled with a beta blocker and on anticoagulation, and sign your name so you kind of covered your butt that this patient is you're doing all the things you need to reduce the risk of stroke and avoiding dangerous conduction abnormalities that can happen if you're not rate controlling this patient. All right, so atrial flutter. So this is also pretty classic, easy to recognize. So again, I want you to remember that this is what the board's gonna throw at you is like really easy and straightforward rhythms, but we're just having more in-depth conversation about these things so that you're ready for clinical practice. But atrial fibrillation is just one atrial ectopic focus, but it fires really rapidly. So the rate is more than 250, and that's why you're seeing this sawtooth appearance in that P wave, because it's that one ectopic beat kind of firing off. It's coming from the same place. It's going to be a very classic look. You can't calculate the PR interval because there are multiple P waves, but that QRS is narrow, so it is an atrial beat. And so I'm sorry, I'm getting a little distracted. That's our alarm system here in Texas. It goes off on Wednesdays at noon. I forgot about that. So hopefully if you're hearing it, don't be concerned in the background. That's just our alarm system. So what were we talking about? So with atrial flutter, you're going to see multiple P waves before you see one QRS. So that's the classic appearance. So with this patient, again, you want to make sure that they do see cardiology and they look into their intervention options, but you're likely going to be you're rate controlling this patient as well. And you're going to be rate controlling this patient as well. And they might also be recommended ablation or cardioversion. Okay. Ventricular arrhythmias, these ones can be intimidating, but let's start with a nice and easy one, premature ventricular contractions. As I was thinking about this presentation, I was thinking, I really like PVCs. Are called PVCs if you already heard them, because they're pretty straightforward. They're really recognizable. If I had to have a favorite, I think PVCs would probably be my favorite, because typically you have patients coming into the clinic saying, every once in a while I get these like funny little heartbeats and then it goes away on its own in a couple seconds. Maybe I have to take a deep breath, but then it goes away. I don't have any associated symptoms, so I don't get lightheaded, dizzy. You might have to ask those questions. Do you feel like you're going to faint, lightheaded, dizzy? No, nothing like that. It just happens every once in a while. Like I just feel like my heart skips a beat. Is that normal? And so if you get a 12-lead EKG, you may or may not see a PVC on that patient, because remember, your 12-lead is just a 2-minute window of the electrical conduction system. So if that patient is having PVCs rarely, you may not see it on that 12-lead. It'll just come out as a normal sinus rhythm. But then every once in a while, you may see some PVCs and that patient's just cool as a cucumber, not feeling anything. So it's not something really concerning, but something you should be aware of, because you are going to eventually see PVCs on your 12 leads, and you might have to talk to patients about that. What I want to point out about PVCs is that you should do further investigation if that patient is really symptomatic. So what that means is ordering that Holter monitor or that event monitor. I like the 14-day event monitors just because it gives me a good wide window to take a look to see how often are they really having PVCs, and are there any run of PVCs, because that's when this rhythm can become dangerous. So a run of more than 4 PVCs in rapid succession is called a run of ventricular tachycardia. So that's going to be a concern. That is a dangerous rhythm, and you do not want patients in VTAC, ventricular tachycardia. So definitely making sure you're getting that event monitor and then having cardiology interpret it for you. And they'll put in their report if they see any run of PVCs. If they do, they usually call you or they intervene with that patient, because they have to talk about probably rate controlling that patient and make sure that does not happen. But you definitely want to investigate if that patient is symptomatic with the PVCs. So ventricular tachycardia, in this scenario, hopefully you're not seeing it in an outpatient setting. If you are seeing it in an outpatient setting, hopefully you've already activated 911 and the ACLS protocol on this patient. But basically, ventricular tachycardia, it may signify coronary artery disease or MI. And so in this patient, how you know that it's a ventricular arrhythmia, you're seeing this wide and bizarre QRS complex. I don't see any P waves. There's no PR interval because there are no P waves. The rate is really high, so it's that ventricular rate, more than 130. And here you're looking at a monomorphic ventricular tachycardia. So monomorphic means they all look the same, right? And there's different types of ventricular tachycardia. There's a very famous polymorphic tachycardia called torsades de pointes. So you might see that again on your boards, and they're most likely going to ask you what happens if you see prolonged QT in a patient. Basically, you just want to make sure you're asking your questions, your history questions. Have they had any pre-syncope or syncopal episodes? Has there ever been a sudden death in the family? What medications are they taking? A lot of psych meds can prolong that QT interval. And basically, a prolonged QT can lead to ventricular tachycardia, which can be dangerous for that patient. So that's how you're going to see it on the boards. And in this case, in this scenario, you definitely don't want your patient in VTAC, so you're going to intervene again with that 911 ACLS protocol. And so if the pulse is present, you're going to cardiovert them. Pulse is absent, you're going to start CPR, but hopefully help is on the way. And then VFib is a type of cardiac arrest. So in this scenario, your patient's not going to be responsive, and this is a life-threatening arrhythmia. So you are literally trying to save their life at this point. You can see in VFib, the ventricles are not contracting at all. So there's no pumping of the ventricles, they're just fibrillating, and you need to initiate CPR. So this is a very classic ventricular fibrillation, pretty easily recognizable. You might see this on the boards, and they're going to ask you, what are you going to do? You're going to initiate CPR. So again, you're going to use that AED, initiate CPR, and you should have already called or be calling 911 to help get that patient to the hospital and save their life. So big takeaway from ventricular arrhythmias is that they're super serious. So when you think ventricular, think very bad, and these patients need emergent care. So bundle branch block. We're going to talk about a few bundle branch blocks. But basically, a bundle branch block is caused by a block in that impulse to the right or left bundle branches. So remember, the bundle of His breaks off into that right and left bundle and ventricles to help them contract. In a bundle branch block, one of those bundle branches is blocked, so you're going to see a delay contraction. And so the telltale sign of a bundle branch block is you're going to see two R waves. In a left bundle branch block, the left side is firing late, and so the R to R, the two R waves that you're going to see are going to be in those left chest leads. So remember, V1 to V6. So V1, V2 are the right side, V5, V6 is the left side. So in a left bundle branch block, you're going to see this classic M in the V5, V6 leads. In a right bundle branch block, you're going to see the classic M in that V1 to V2 leads. Bundle branch blocks should be investigated and to figure out what is the cause of the bundle branch block and to see if there could be any intervention on that. First degree heart block. So again, you're taking a look, PQRS, 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 PQRS. So you see a P for every QRS, so your P waves are there. Now you're going to measure your PR interval. So you're going to measure those boxes, right? Normal PR interval is between 0.12 to 0.20, so between 3 to 5 boxes. And here you see that that PR interval is long. And you see that it's the same in all of those cycles, right? You have a long PR interval. Your QRS is still narrow, so it's less than 3. And your rate, you're going to calculate your rate. So 1, 2, 3, 4, 5, 6 with a little bit, so a little over 60. So rate's normal, QRS is normal, but that PR interval is prolonged. So this is variable. It could be normal variation from anything from normal variation to to effects of drugs or electrolyte disturbances. So you do want to investigate what a first-degree heart block is, but it's not emergent. So you would refer this patient to cardiology so they can treat the underlying condition. And sometimes there might not be a treatment that's required, but you definitely want to investigate what's happening here. Second-degree heart block type 1, also known as Mobitz 1, also known as Wenckebach, so it goes by a lot of names. There's a little poem I'm going to give you at the end of this presentation, and I'm going to refer to this as Wenckebach. So second-degree heart block type 1 or Wenckebach. So you're going to, again, look for all your parts, right? P, QRS, P, QRS, P, QRS, P, what? Where did that QRS go? You have a dropped QRS right there. Again, P, QRS, P, QRS, P, QRS, P, up, another dropped QRS. So there's not a QRS for every P wave, right? And then what's happening with your PR interval? So you're going to measure your PR interval. And as you can see, as you're measuring it, it's getting longer and longer and longer, and then up. There's the dropped QRS. So the classic sign for type 1, second degree type 1, is you're going to have that prolonged P and then a dropped QRS. Your QRS is still narrow, so it's less than 0.12, and your rate is variable because you're getting that dropped rhythm, right? Dropped complex. So your rate is going to be irregular. And so you do need to investigate the cause of type 1, and we need to treat the underlying condition. In patients who may be asymptomatic, there might be no intervention, but in patients who are symptomatic, you probably need to pace that patient. So getting them over to cardiology to figure out what's happening. You're most likely not seeing this in the outpatient setting. Usually this happens post-op after cardiac surgery. So if you think about like heart valve replacement procedures, that atrial valve is right where the AV node is. So when they do an atrial valve replacement or they're doing any kind of cardiac manipulation and surgery, that may affect that AV node in the conduction system, right? So typically we'll see this in post-op care. That's why usually patients stay at least 24 hours in the ICU, cardiac ICU, after they've had cardiac surgery so that they can monitor for this type of heart block and intervene by putting in a temporary pacemaker until they can get a permanent pacemaker. And so second degree heart block type 2, Mobitz 2, so same thing. This one's a little bit more dangerous. And what I mean by same thing is it's sitting right, it's most often happening after cardiac surgery just because of where the atrial valve sits and where the AV node is in the conduction system. So in this patient, they're more hemodynamically unstable because of the bradycardia, and we'll talk a little bit more about that, but you worry about progression to third degree heart block, which is complete heart block, which is the most serious. So again, these patients are going to be really closely monitored in post-op to make sure that that's not what's happening. But here, the difference between second degree heart block type 1 and 2, so you're looking at that P for QRS, P for QRS, P, there's no QRS, there's a drop. So the same thing is happening. It's going to be a dropped QRS. So there's not a QRS for every P wave. But look at the PR interval. So the PR interval is not elongating, right? The PR interval is just kind of marching along at the same. There's no elongation of the PR interval. So that's the difference between type 1 and type 2. But again, look at the rate. The rate's going to be, it's going to be an irregular rhythm because you have that dropped QRS, and then the rate is going to be slow because again, you have that dropped QRS. So look at this rate, 1, 2, 3, 4, 4.5. So the rate is 45 less than 60. That is concerning. So again, this is a patient that needs to be monitored very closely because of this bradycardia. And then most likely you're going to see this on the inpatient side, and they're going to be temporarily pacing this patient until they can get a permanent pacemaker in. And then lastly, we have third degree heart block, which is complete heart block. So this is, You never want complete heart block. That's a horrible name, and there's a reason for it. So in this case scenario, we're going to take a look, and what you'll see is the P and the QRS are not talking to each other at all. They're marching to their own drum. So you're looking, there's a P and a QRS, there's a P, where's the QRS? P, QRS, P, where's the QRS? And then if you march it out, so the PR interval is variable because there's just not a P for every QRS. That QRS complex is narrow, so that's fine. But what's happening is if you take a little measurement of it, the P waves are marching regularly. The R waves are marching regularly, but they're not talking to each other at all. So they're just marching to their own drum, their own beat. So that's a pretty classic sign of third-degree heart block. Again, this is a situation where this patient needs to be monitored very closely, and they're going to put in a temporary pacemaker until they can get a permanent pacemaker put in. But this is a dangerous rhythm. All right, so as promised, here's our little heart poem. If this is the way you want to remember it, hopefully you understand these rhythms, but some people, get test anxiety, so they want a little poem to make sure that they're, they've got the right rhythm when it comes up. So heart block poem, if the R is far from the P, then you have a first degree. So you remember in first degree block, you have that elongated PR interval. So everything is consistent, but it's longer than the 0.12 and 0.2 seconds. In longer and longer drop, then you have a Wenke Bach. So Wenke Bach is that second degree type 1. So remember that PR interval is going to get longer and longer and longer, and then you're going to get the drop in the QRS. If some P's don't go through, then you have a Mobitz 2. So Mobitz 2 is that second degree type 2. So you're going to get that dropped QRS, but you're not going to get that longer and longer PR interval. The PR interval is pretty consistent. So that's the difference between Wenke Bach and Mobitz 2. And then if the P's and Q's disagree, then you have a third degree. So again, in the third degree, the P's are marching to their own music, to their own drum, and the QRSs are marching to their own music. So you're going to see complete disagreement between the P's and the Q's. So they're on their own wavelength. So, all right, let's see if I can read these practice questions. So on my monitor, it's gotten pretty small, but let me see if I can make it a little bit bigger. But now we're going to go through some practice questions. So here, I want you to enter your answers into the chat. We're doing well on time, so we have some time to go through these practice questions. So QT prolongation predisposes an individual to what arrhythmia? So is it A, torsades, B, sinus arrhythmia, C, AFib, atrial fibrillation, or D, third degree heart block? And I'll give you some time to answer. And I see there are 3 of you on today, which is great. I love that you're joining me today. Don't be shy about answering. Remember, we talked about that QT prolongation that's going to come up on the boards. So what are we worried about with QT prolongation? What does the boards want you to make sure that you're preventing? It's that ventricular arrhythmia. So a prolonged QT can lead to a ventricular arrhythmia like torsades, and torsades is a type of ventricular arrhythmia. So they just want to make sure that if you do see a prolonged QT, you're going to investigate that. What is the cause of the prolonged QT, and can you fix it so that it doesn't lead to a dangerous, life-threatening arrhythmia like ventricular tachycardia? All right, next question. A 60-year-old female comes into the clinic with shortness of breath that suddenly occurred. She describes it as if she was running a marathon but hadn't moved. So shortness of breath at rest. She is also complaining of intermittent jaw pain. What should be the priority action with this patient? So remember, she's 60 years old. She's complaining of shortness of breath at rest, and she's getting referred intermittent jaw pain. So what are you thinking? Is this acute or not acute? And what's going to be the first thing you're going to do? Are you going to assess the lung sounds? Or B, take vital signs? C, perform an EKG? Or D, all of the above? So what is going to be the first thing you're going to do? So if you were thinking choice C, you're going to get that EKG, you would be correct. So remember, in both men and women, chest pain is the most common sign or symptom of heart attack. But in women, women often experience other atypical signs and symptoms. So in this scenario, women often experience shortness of breath, and they could have chest pain that radiates to the back. So they could describe it as back pressure, jaw pain. So you also want to be mindful of atypical signs and symptoms with a cardiac etiology. So you want to ask those history questions. Have you had any pre-syncopal events? Any syncopal events? Are you feeling short of breath, lightheaded, dizzy? Is it getting harder to do your regular activity? Are you feeling short of breath when you're talking? Any referred back pain, sharp pain to the back, any jaw pain? I once had a patient who all of a sudden started having referred jaw pain when they were working out on the treadmill. Very fit individual, but all of a sudden started to have referred jaw pain. And sure enough, cardiac evaluation showed significant coronary artery disease. So you definitely want to make sure that you're looking for those atypical signs, especially in our female patients. So some additional resources that I wanted to bring to your attention. We don't have time today, unfortunately, to go over this EKG game. I was really hoping we would, but I'll go ahead and put this in the chat too, so that you have this link and you can go on and practice. But when I was studying for my boards, this game existed, and it has a nice little practice feature. It also has a game feature, and it really helps you go through different rhythms so that you can get used to and more familiar with identifying different rhythms. So it's a fun interactive tool to help learn your different EKG strips. The other thing I wanted to bring to your attention was this book called Rapid Interpretation of EKGs by Dale Dubbin. Or however you pronounce it. I have no stock in this book, so this is not like a personal plug. This is really something that helped me when I entered clinical practice. One of my physician colleagues recommended it to me when I got into clinical practice. I felt really overwhelmed by 12 leads, even though I knew my rhythms. There's a lot going on in the different leads. And so this book really helps break it down. And it's nice to have in your Amazon bucket for later. Once you've gone through the boards, order it, have it in your library when you're in clinical practice, so that you can pull it out and say, what am I seeing? Why am I seeing this? And you can reference different sections. It really does break it down. It's like a how-to dummy guide that I really enjoy and still sometimes reference to this day. So it's a nice book that I highly recommend to all of you. As I mentioned in the beginning of our webinar, we do have, this is part 1 of 3 for the cardiac system. So cardiac is a big portion of your board. So we've broken it down to 3 sections. Parts 2 and 3 are next week. So Monday, my colleague Brittany is going to give a fabulous talk with cardiac part 2. On Wednesday, I'll do part 3. And then on Friday, our colleague Morgan is going to talk about the musculoskeletal system. So we've got 3 awesome live webinars next week, Monday, Wednesday, Friday. Make sure you check those out. We'd love to see you. And as always, you can scan this QR code to sign up and register for all future webinars. So those 3 webinars that we talked about. We have an amazing 3-day review coming up that's going to cover everything that you need to know for your board. So be sure to check that out. Don't miss out on that. And of course, our Q Bank. We have almost 1,500 questions in our Q Bank. And I think Rachel on Monday was saying that we're about 14 questions shy of reaching that 1,500 number. So definitely check out our Q Bank. Our amazing team of FNPs make sure they put new questions in every week, and lots of good questions to practice and get ready and build confidence for your boards. Check us out on our website and our social media accounts. And then if you have any questions, as always, you guys can email us directly at fnp@archerreview.com. And we'd be happy to support you through not only your clinical journey now, but also your clinical journey when you enter practice. So thank you so much for joining today. I'm going to stay on and open it up to questions for the next 5 minutes. If anybody has any questions on what we talked about today, please feel free to put it into the chat. Otherwise, we hope to see you next week for parts 2, 3 in that musculoskeletal live webinar. All right, you guys. I'm not seeing any questions in the chat, so either you're feeling very confident or very overwhelmed. I hope it's the former. But again, please feel free to reach out to us with any questions. Thank you so much for joining us today. I'm going to go ahead and close out the webinar, and hope to see you next week.